You know that I consider, can y'all hear me back there? Can you hear me back? That I consider Steve to be a friend, one of the smartest CEOs I know. He's going to shoot me for saying this next thing. Steve is kind of like, some of y'all might be old enough to remember the John Houseman Smith Barney commercials, when he said, when Smith Barney speaks, everybody listen. When I'm at the meetings and Steve's there, when he speaks, we all listen. I'm sure you'll find that out when you hear his talk. Now for the top 10 facts about, top 10 Steve facts. Steve is the CEO of Bjc Healthcare, one of the nation's largest healthcare organizations with $5 billion in net revenues, 15 hospitals, and more than 31,000 employees. And last night we found out that the practice plan, which is how many employees approximately?
1,500.
Is about
1,500 doctors.
About 1,500 doctors, has a revenue of about $1.2 billion, which we're still trying to, Selwyn and I are still trying to figure out how that could be, because that's about twice our revenue. So those from HSF, y'all got a way to go. Barnes Jewish Hospital and St. Louis Children's Hospital are affiliated with Washington University School of Medicine, number 2. Number 3, Steve serves as the executive board chair of Bjc Collaborative, an 8 health system organization spanning eastern Kansas, all of Missouri, and southern Illinois. 4, Steve serves on, that is much better. Steve serves on, thank you ma'am. Steve serves on the board of directors of Amerigen, an electric utility company, and Teach for America. 5, this one's amazing to me. He's on the board of trustees for 2 universities, Washington University and Emory University. He might be a glutton for punishment, I don't know what to say. But, 6, this is really impressive. Steve is former chairman of the board of directors of the St. Louis Federal Reserve Bank. So if you've got any economic, we want to know where to invest your stocks? Ask Steve. In 2013, he was named St. Louis Citizen of the Year. In 2014, he was elected for membership in the National Academy of Medicine. Number 9, he has academic experience at Mass General, Johns Hopkins, and the University of Chicago before coming to BJC in 1999. And number 10, he's going to shoot me for saying this one too, but this is the truth. Finally, I can say for a fact, since I know her, that most of his success is because of his wonderful wife, Susan. And if you knew her, you would agree with that. I'm sure you will learn a lot today. Join me in welcoming Steve Lipstein to UAB in Alabama.
Good morning. You can hear me too? Good. It's really interesting. I mean, talk about a divided country. The people in this room are either all the way to the left or all the way to the right. But thank you for having me this morning. And I'm hoping that I will be able to go through kind of what I prepared pretty quickly, so perhaps we can have a conversation and talk about questions and issues that you want to talk about. Last night at dinner, Dr. Jones, hi Tony, asked me what the take-home message was going to be for my talk today. And then I realized it had to have a take-home message. And so I actually went back to my room and began to think it might be better for me to just, as we go through the slides, for me to tell you what the take-home message is on each slide. And what I'm hoping to share with you this morning is that the world around us is changing pretty dramatically. And as you heard from Will, I do get to work with other universities and their health sciences centers and academic medical centers, including at Emory and at the University of California, and at Washington University. And so I realize and I know that all of these places are just a little bit different from one another. But the University of Alabama, Birmingham has always had kind of a rich legacy of being at the vanguard of academic medicine. And so part of my question here today is, the future of academic medicine, is it rosy or rocky? I'm not going to answer that question for you, but what I'm hoping, my aspiration is that by the end of this talk, you'll have some insight into that. But more importantly, you'll be, I'm hoping that you'll leave thinking, okay, what is my role in determining that outcome? What am I going to be one of the leaders in putting my slides back up. Now, am I going to be one of the leaders in protecting and nurturing and advancing the legacy of the University of Alabama at Birmingham? Or am I just along for the ride? Or am I going to be one of those kinds of wait and see people? And part of the reason I was really excited about coming here is I think you all are in positions to determine that future and to determine the outcome to this question. The cover slide is kind of the first kind of takeaway message, okay? In that I put this graphic at the bottom on purpose because it used to be when I started out at Johns Hopkins Hospital. This was in 1980 something, like 2. I think we used to think that in academic medicine, in the world of education and research, we were figuring out new, different, and better ways to take care of patients. We would train our students and our residents on how to do that. They would go off into the healthcare delivery system and change the world, change the way we deliver healthcare, and then we would figure out a way to get everybody to pay for what we were doing. Whether it was to get the government to pay for what we were doing, or the insurance companies to pay for what we were doing, or the National Institutes of Health, we all thought it kind of worked in reverse. And what I'd like to do is try and convince you that that's not going to happen in the future. That in the future, things about the United States population, socio-demographic information in particular, is going to change dramatically, which is going to force a change in the way we finance American healthcare, which is going to force changes in our delivery system, which then is going to drive changes in how we educate the next generation of physicians, nurses, healthcare professionals, and it's going to broaden our world of research beyond the health sciences into how we actually achieve better health outcomes, in part, many of which are not driven by what we do in the clinical arena, but really what happens in our communities. Okay? So that's the general construct. The take home from this slide is this is about the only 3 things I'm sure that Democrats and Republicans agree about. Everybody agrees about the triple aim. And so you've seen this before, and you know that this is where the Obama administration said we were headed. Even when we were talking about repealing and replacing Obamacare, these were still the overarching goals. Okay? The next take-home message is that the Affordable Care Act, or Obamacare, is not the only thing that happened to you or the American healthcare system over the last 10 years. A lot of other stuff happened. And I'm going to go up this pyramid really quickly. Remember, the goal at the summit is still that triple aim of improving health, improving the quality of care and service, and in lowering costs. But in 2009, when we passed the stimulus bill, you all remember that our economy went through a very, very difficult time in 2007 to 2009. The government decided to stimulate our economy, and in that stimulus bill was $19 billion to transform all of you into meaningful users of health information technology. Your epic journey, I think you use Cerner here. Your Cerner journey may have started before that, it may have started after that, but it has certainly changed in almost every academic medical center. The Affordable Care Act would be a talk into itself, but let's keep going on top of that. You remember the sequester, the budget balancing bill of 2011, where we actually put some growth parameters on defense spending and every other sector of the federal budget. That resulted in a 2% reduction in your Medicare payments. Okay. Then you keep going up, and you'll remember that we had this debt ceiling fiscal crisis issue once before in 2013, and in order to get agreement to lift the debt ceiling so that the United States could continue to finance its federal budget deficit, there was a further reduction in Medicare spending. So for an organization like BJC, okay, which is, as Will shared with you, is about $5 billion in revenue, a 3% reduction in Medicare spending is more than $30 million a year. So it's a big number in most of our academic medical centers. But as we keep going up the pyramid, and I'm going to cover some of these in really, really fast, because I'm looking around as a knowledgeable audience. You're familiar with alternative payment models. You're familiar with value-based purchasing. You're familiar with MACRA. And you know that there are other budget challenges that are still ahead of us in the federal dialogue. So the take-home message here is, while the country and the media may be focused on this one thing that happened in the last 10 years, a lot of other stuff is going on in American healthcare. So I'm going to talk to you briefly as we go on this journey about 4 significant trends that are going to shape the financing system of American healthcare, that are going to drive changes in the delivery system, and then we're going to come back and talk about how that affects the educational enterprise, the research enterprise. So we're going to cover each one of these in sequence. So the Medicare math is really, really important. When we passed the Medicare well, first of all, does everybody know how Medicare works? For those of you in the room who make less than $250,000 a year, you pay 1.45% of your paycheck every pay period, and you send it off to Washington. They put that money in the Medicare trust fund, and they don't save it for you. They pay Medicare claims with that money today. And today, well, actually when the Medicare program started, there were 5 of you working, sending money off to Washington for every single person on Medicare, okay? And in 1965, when they had 5 people paying in for every person on Medicare, they thought the average life expectancy was going to be 72. Because you can go back, and I'm going to talk about the differences between life expectancy when you're born and life expectancy at age 65, which are dramatically different in our country for a very good reason that I'll also kind of come back to. But in any way, think about that. There were 20 million people on Medicare in 1965, and they were only expected to live to an average expectancy of 72, okay? You all have screwed that up pretty good. So now, as you know, back in 1965, are there any orthopedic surgeons in the room? Just one. Wow, that's very unique. But anyway, we couldn't replace your knees, your hips, your elbows, your shoulders. We weren't rebuilding your spines back in 1965. For the cardiologists in the room, we weren't implanting defibrillators, pacemakers, stents, valves. Catheters were just starting. For the oncologists in the room, a stage 3 or a level 3 diagnosis of cancer back in 1965 was almost immediate, a prediction of immediate and certain death. Now we have advanced chemotherapy and radiation therapy, and I haven't even gotten to the transplant activity yet. All of that activity, combined with advances in public health, antibiotics, immunizations, life expectancy in 2015 is dramatically higher. Now you would see, by the way, for people who make it to age 65, our life expectancy is almost as good as it gets in the world, okay? Some smaller countries that are much less diverse than we are may have longer life expectancies. But at age 65, right now they're predicting that the men in the room get another 19 and a half years, and women get even longer than that. So this idea that we're going to have an insurance program called Medicare that's going to provide you with comprehensive medical care up until the day you die, after you reach age 65, we have a math problem because people are living a lot longer than those 7 years, and there are going to be a lot more of them. And so if you come all the way down on my slide here, you can see that, okay, right now we know that there's only going to be 2.5 of you working for every person on Medicare once I get there. Okay? Once I get there. So we can solve this problem only one of 4 ways. Okay? When I get to Medicare, you can say, we're going to increase the age of eligibility because we only promised you 7 years of health insurance. So now you're going to live to 84. We can't start covering you till you're 77 instead of at 65. Well, that doesn't feel too good to the person who votes for somebody in elected offices. So you're not going to vote for me if I advance the age of eligibility dramatically. You can come to me and say, Steve, we promised you health insurance, but it's not going to cover orthopedics, it's not going to cover oncology, and it's not going to cover cardiology, but it'll cover everything else. I'm not going to vote for you if you're going to change the benefit plan that dramatically. You could, you could say, you know what? for the 2.5 workers for every person, we'll just increase their taxes by a lot, okay? Practically double them. I doubt you're going to vote for me under those circumstances either. And so the last solution, the only other one I can think of, is that we're going to have to pay you all very, very differently to take care of all these people over the age of 65. Okay? Now, there's a really important difference between, do we have a life expectancy problem in the United States? I just want to leave you with this one. Or do we have a poverty problem? Okay? America has the highest poverty rate in the developed country world, except for Korea and Mexico. Okay? So when you see that Japan, Switzerland, Iceland, Norway, in the academic literature, you love to see comparisons about our life expectancy or our health systems compared to those. You never see that adjusted for socio-demographics usually, because we have a very high poverty rate, which is why life expectancy, by the way, at age 65 compared to birth is so much higher, because there's a real correlation between poverty and infant mortality. Okay, and infant mortality is death in the first 2 years of life. If you take that out of the math, America's math looks almost as good as any other developed country in the world. So that's kind of the take-home of the Medicare math problems. Everybody kind of, okay. We're going to skip over the Medicaid math pretty quickly, because you live in a non-expansion state, and so do I. The take-home from this slide is that because the Medicaid expansion program, part of the Affordable Care Act, was judged to not be constitutional, a violation of state rights, 31 states took the expansion, 19 did not. The difference now in federal money that flows to the expansion states versus the non-expansion states is substantial. There's $1,600 and some dollars sent to every state per person to support their Medicaid program in the state of California. In the state of Alabama, that's about $800. Okay, so and Missouri is the same way. So the non-expansion states are getting about half the federal money to support their Medicaid programs per person in the population than the expansion states. Interestingly enough, in the blue states on that map lives 2/3 of the nation's population. Okay, and if Texas, Florida, Georgia, and North Carolina were to take the Medicaid expansion, it would be 85%. I'm not saying that Alabama and Missouri aren't important, but we're not where the population lives that isn't getting covered largely by that Medicaid expansion. Okay? This one you all know. I'm guessing that at the University of Alabama, Birmingham, you contribute to your health insurance premiums, and so does your employer. And basically if you look at your paycheck every year, you're seeing that your wages aren't growing at the same rate that your health insurance premiums are growing, or that the rate at which your deductibles are growing. This slide, by the way, shouldn't be a surprise in terms of its curve. Whenever we bring down after premiums go up, deductibles can come down. When we take premiums back down, deductibles go back up. We haven't figured out a way to actually lower the overall cost yet. We're just shifting money between premium and deductible, and both premiums and deductibles are going up faster than wages, and all of your employees are aware of this. And then finally, when you look at the percentage of the population that doesn't have insurance, in both the expansion and the non-expansion states, the rate of the uninsured was coming down until 2016. So the latest data basically shows that the rate of uninsured in the states that expanded Medicaid, and to give you an example, 1 in 3 people in the state of California is covered by Medi-Cal, their Medicaid program. Does that affect the University of California health system? UCSF, UCLA, UCSD? Absolutely. And now the rate of uninsured in the non-expansion states is beginning to go back up again. Okay? So those are all the context that I wanted to provide that basically says these demographic trends, these population trends, have to change the way we pay you for what you do in academic medicine. Tony, how am I doing so far? Is that a take-home that we've... Good. So now I want you to, if you could, divide the American healthcare system up into 2 big boxes. One I call an episodic facility-based delivery system, and one I call a population or a people-based healthcare system. One is episodic care, and think of episodic care as I call you, I schedule an appointment. I come to that appointment, and then for an episode of illness or injury, you take care of me, and then I go away. And you don't ever talk to me again until I call you again. You may follow up with a follow-up phone call to see how my surgery went, how my recovery's gone, but essentially it's limited to an episode of care. And you provide that care in outpatient centers. You can provide them in community or specialty care hospitals or in teaching hospitals. The other healthcare system is a people-based healthcare system. One where I have really not a two-way dialogue with my doctor. He's always contacting me, I'm always contacting him. And they follow me wherever I go. Not just in my home, not just in their office, but where I work, where I go to school. And so there's a real continuing care relationship. I would argue that in America, we really don't have the top part of this healthcare system. Now, some systems like Kaiser would say they do. Okay, some systems could argue that they do. But by and large, I still interface with the American healthcare system when I contact you, not when you contact me. When I go to your emergency room, when I call to schedule an appointment, and I'm still, even my interaction with my primary care doctor, and I've been a student of healthcare for like 35 years now, my interaction with my primary care doctor is still largely episodic. So the first thing you got to do in your head now is figure out, where's the University of Alabama, Birmingham? Are we an episodic care delivery system here? Are we a people-based healthcare delivery system here? Those financing changes that are taking place, and they're on the left, and I'm going to give you evidence that these financing changes are real, but I'm not going to explain them because I don't have enough time to explain each one of these. But I know you're an evidence-based group of people. You need evidence in order to be convinced that something is real and it's happening to your organization. And so these changes in financing are affecting the episodic care delivery system. And so if you take out the letters BJC and you put in the letters UAB, this wouldn't be very different. UAB probably has pay-for-performance arrangements across a variety of payers, and they include both the government and the private payers, and you probably have performance measurement scorecards, and you're looking at metrics that are being promulgated by the insurers. You are all subject to paying penalties for variation. Unless you're much better than BJC, you're probably paying some penalties for variation. The big issue on this slide for me is that none of this data has ever been risk adjusted for sociodemographics. So I have 15 hospitals inside of BJC Healthcare. The two largest penalty payers are our two safety net hospitals. But according to the government, and if the readmission rate at Mayo Clinic, I'm going to take this away from BJC and UAB, if the readmission rate at Mayo Clinic Scottsdale is very low, and the readmission rate at Henry Ford Health System is very high in Detroit, Michigan, if you were to reverse those doctors, if you take the Mayo doctors and send them to Detroit, they would have a very low readmission rate. And if you take the Henry Ford doctors and you put them in Scottsdale, they would have a very high readmission rate. Nobody in this room probably believes that. In fact, there really is a difference when your poverty rate in Scottsdale is 4% and your poverty rate in Detroit is 34%. Okay? So I would argue that we haven't. And you might say, well, we want the same standard of care for people who are wealthy and people who are poor, and it's absolutely true. But it's also true that physicians and nurses respond to economic incentives. And so if the federal government is going to punish you, penalize you for practicing in Detroit, do you avoid that risk and go practice in Scottsdale? And what we're finding is, since we put in these penalties for variation, disparities in outcome among social classes and races have widened, not narrowed. Okay? So if what you're doing isn't solving your problem, you keep doing the same thing. I'm not going to go over bundled care. I'm assuming that you understand the gist of bundled care payments, that basically, and my orthopedic surgeon is probably the best example in the room, where you basically take the pre-procedure, the procedure, and the post-procedure period for about 90 days, and you make one payment to the care provider team, and they'll do a better job of coordinating. I know this would work for BJC, because my wife Susan, who does have MS, who has MS, also had a hip replacement. She had a care manager who was assigned to the orthopedic surgeon before the procedure. Then we were in the hospital for about 36 hours, where we got the hospital care manager to coordinate our care. Then we went to the rehab hospital because of the combination with MS and joint replacement. We got a third care manager, and then we went to BJC Home Care, where we got a fourth care manager for one episode of care. Now, because I think, people knew I was the CEO, that was relatively coordinated until this is a true story. The care manager at the hospital called an ambulance to take Susan to the rehab hospital, and that ambulance was out of network. Okay, so even within the BJC system, bundle payments, would make a big difference. For the oncologists in the room, and I think I saw somebody nodding when I was talking about oncology earlier, you have your own bundled care model. And so you're probably very familiar with it. It has a lot of detail to it. It's very complicated. And you would probably imagine that if you're a private practice oncologist, the federal government is about to overwhelm you with new and different payment models. Part of the reason that I've given examples in orthopedics, oncology, and coronary ablation is those are the three top spending categories of the Medicare program, okay? And so Medicare doesn't believe it can solve its math problem if 80 million people are going to want joint replacement surgery until they're 84 or 87. They don't believe they can solve their math problem because we spend a lot of money on off-label use of chemotherapeutic agents in the last 2 years of life. And they don't think they can solve their math problem as long as we're trying new and different and very expensive ways to remove blockages from your coronary arteries. Now we're going to talk about we're going to move away from the episodic healthcare delivery system up to the people-based system. And these are what we call the two ideas to change the people-based system or to force the development of a people-based system are going to be shared savings models or full risk models. And you all have a lot of experience with one called Viva Health. I went for a little run downtown. I saw this big sign, Viva Health. I said to Will, what's that? And he said, that's us. But inside of that plan, you have a Medicare ACO or a Medicare shared savings model, Medicare Advantage plan. And that makes you completely accountable for all the costs of care associated with a defined population. That's kind of what the government, Medicare and Medicaid, are driving us towards. And to keep in mind that Medicare and Medicaid are probably over 50% of your paycheck. That over half of your paycheck in academic medicine comes from the federal and the state government. Less than half probably comes from commercial payers. So both payers are saying we have to figure out a way to cap the total amount of money we spend on healthcare because the nation has an affordability problem, and the way we're going to solve that affordability problem is to introduce these models where we give you a fixed sum of money and then you become accountable for how that money gets spent. And these are really happening. These are evidence slides that basically say we have over 800 ACOs, and about half of them are CMS models. BJC, for example, does have a Medicare ACO with about 40,000 attributable lives. And then you also do have inside of Viva Health, you do have a Medicare Advantage product. And back here in 2005, I might have said, we in academic medicine, we don't need to pay attention to this. It is such a small percentage of the Medicare program. But it has grown dramatically, so now almost a third of everybody in Medicare is covered under a Medicare Advantage product, which means that increasingly this program is going to push us to accountable care models. Everybody kind of with me so far? Good. So now we get to the fun part. So I'm asking you, before we go to this, is where is UAB today? Is UAB an episodic facility-based care delivery system, or is it a continuing people-based healthcare system? And is it well-positioned to respond and adapt to these financing changes that are going to happen and are happening in real time. And so then I pose the next question, which is, can any standalone health system, the UAB health system, any academic medical center, create a total cost of care accountability system for all by itself? Now, Viva Health has about 100,000 members today, and the metropolitan area population is about 1.1 million people. So let's say about 10% are in Viva Health. That means 90% are going to find their way or migrate their way into an accountability care system over the next couple of decades. And so if you buy the construct that you need to take your episodic care delivery system, which is absolutely essential, because there are still lots of episodes of illness and injury in our society, and you need to marry it up with a people-based healthcare system, that's the only way you get to a total accountability of care model. And so in order to kind of explain total accountability care, I need to do another math lesson real quick. And this is a quick math tutorial. The average premium for healthcare for an individual in the United States is about $8,000 a year. I rounded it up to $8,100 so that I could then divide it by 12 and get you a monthly premium of $675. The data, according to risk stratification, actually comes from the state of Iowa. I wasn't allowed access, by the way, to this data in Missouri because the payers aren't allowed to share it with me. But I went to Iowa because we have a mutual friend in Iowa, and he shared the data from his accountable care organizations across the state. And what I learned was that if you're healthy, if you have no chronic conditions, it costs about $150 a month to take care of you. And so if you're getting a premium of $675 and people in your health plan are healthy, you've got a nice margin, right? It turns out that then you get the low risk, and I'm talking about people with just one chronic condition. Just have diabetes, just have congestive heart failure, just have a minor episode of illness or injury. They tend to be low risk. And even then, if the only people in your waiting room are healthy and low risk, and you're receiving $675 a month, you're still okay. Now you get into the rising risk and the high risk and the malignancy and the catastrophic categories, and the dollars then begin to mount up. So it turns out, and I kind of wrote an article about this one way called The Waiting Room, you need a lot of people in your waiting room paying you $675 a month so you can make sure that about half the people are healthy or low risk, and maybe the other half have rising risk, high risk, malignancies, or catastrophic illnesses, but you obviously need to spread the cost of the people at the higher end of the risk strata across the people at the lower end of the risk strata. Does that make sense? And so once you understand that math, then you say, what do you really need to have at the University of Alabama, Birmingham to be a total cost of care accountability system? So the first thing we talked about is a large, diverse, and inclusive risk pool. It'd be wonderful if you could just have healthy and low risk, but you can't, because the very identity of the University of Alabama at Birmingham, the very identity is about taking people who have rising risk for health conditions, or high risk, or have cancers, or heart disease, or injuries, and so you know you're going to get a risk pool that skews towards the people at the bottom end of this continuum. The second thing you're going to need is money. And it isn't money that we can spend on academic medicine. We can't spend this money on research. We can't spend it on recruiting new chairs. We can't spend it on attracting young faculty because we need to keep it in the bank. And the reason we need to keep it in the bank is because sometimes we have to pay bills before we get the premium. So sometimes, like in a year's worth of time, if in January and February we see a lot of sick people, we still have to pay those claims, even though we won't collect the premiums until July through December. And this is called risk-based capital, and everybody has it. So Viva Health has a pool of risk-based capital that they use to pay claims even before premium revenue comes in. Okay? But the interesting thing about academic medical centers, and I've been through this conversation with leaders at Vanderbilt and Emory and now at UC in California, is that if you set aside this money to take on total cost of care accountability risk, it diverts money away from your academic mission. And that's a real dilemma for us who are leaders of academic medical centers. The next thing you need are data analytics, and the reason I say data analytics, you have to be able to take all the electronic medical record data, all your claims data, all your pharmacy administration data, and all of your socio-demographic data and put it into a data analytics engine that then produces this stratification. And I say socio-demographic data. If you live in poverty and you have diabetes, in this world you have two chronic conditions, okay? You don't have one. If you live under disadvantaged life circumstances, obesity and diabetes, substance abuse and diabetes, you can begin to see that social factors, lifestyle factors, are equally weighing on the risk stratification. Once you have this risk stratification, it turns out that the two populations where you have the best chance to manage the cost of care lower are in the rising risk and high risk categories. You really aren't going to do a lot to change the cost curve on the healthy or on the low risk, and you're not going to do a lot to change the cost on the malignancies or on the catastrophic illness. But these are the two categories where care management models have proven to have the greatest impact on total cost of care. And then finally, because of your reputation as attracting the sickest of the sick, the people at the higher end of the risk continuum, you probably are going to need friends. BJC is pretty big. We're 15 hospitals, and as Will shared with you, about $5 billion in revenue now, and that doesn't include our practice plan, and we still think we're not big enough. And one of the things I shared with Selwyn and Will and Tony last night at dinner is that in order to get to a patient population that's really large and diverse, I need the whole state of Missouri and all of Southern Illinois, which gets me to about 11 million people, which is smaller than New York. So we don't live in big population centers, which is something that is a challenge for academic medical centers as large as we are. So BJC, I'm going to now tell you who our friends are. And when I say BJC, I'm not talking just about Barnes Jewish Hospital and St. Louis Children's Hospital, which is the two anchor hospitals of our academic medical center with Washington University. Those are the hospitals you see in Metro Central, and they're kind of in what we call the central west end. They're not downtown St. Louis, but they're in the city. We have two hospitals to the north, two hospitals to the northwest, two hospitals to the west, one hospital to the southwest, one to the south, and the medical school practice plan has ambulatory campuses in the south and in the west. And so you can see that we built a fairly large delivery system in a population center of about 2.8 million people. The idea here is that the academic medical center campus, Barnes Jewish and Children's, they needed friends. They needed diversity and inclusion. They needed scale in order to be a total cost of care accountability system. And they needed access to other revenue sources. And so this is our circle of immediate family, okay? But even then, and this just, I wanted to give you a sense of what BJC is in terms of developing different venues of care. The infrastructure you might need for both an episodic care delivery system and a people-based delivery system. So we have the employed physician group at the very top, largely engaged in episodic care delivery. But then we have a large home care group, a hospice group, a workplace health group, a community mental health center group. We have a rehabilitation hospital. We actually have a joint operating agreement with a long-term care company because it turns out that long-term care wasn't our sweet spot. We didn't really do it very well. And then we obviously have a big community outreach, school-based outreach group, which we call BJC in the community, and then we're also in the schools. And then we do have an employed physician group that is separate from our medical school. And this is going to be a little bit different than what you have here at UAB. We do all of our total cost of care accountability contracting through the BJC Medical Group, which is not an employed physician group of the university. Most of the people at the top of the slide are specialists. Most of the people at the bottom of the slide are either primary care, advanced practitioners, or hospitalists. There are a few specialists in that group who tend to practice in rural hospitals or in venues where the medical school just doesn't want to be. Okay? That for us wasn't big enough. So we created something called the Bjc Collaborative, and this is kind of where I'm going to finish up so that we have at least about 10 minutes for questions. So I shared with you earlier that in order to get to a population of 11 million people, we would need to cover the whole state of Missouri and Southern Illinois. The only people that were calling us to want to be a part of BJC were hospitals that were in distress. Okay, so we decided that wasn't going to work, so we got in touch with the people who do what I do for a living, the CEOs at Cox Health in Springfield, Missouri, St. Luke's Health System in Kansas City, and Memorial Health System in Springfield, Illinois. All of these health systems have affiliated medical schools. St. Luke's is affiliated with the University of Missouri, Kansas City, Cox Health with the University of Missouri, Columbia, and Memorial in Springfield with Southern Illinois University School of Medicine. And through the relationship with Memorial, really, in addition to having 4 founding members of the Bjc Collaborative, those largest healthcare not-for-profit systems with an academic mission in the largest population centers, we were also able to bring in 4 smaller health systems that wanted to be a part of our collaborative that were in the Bjc 2-hour drive radius. Blessing Health System in Quincy, Decatur, Memorial, Sarah Bush Lincoln in Mattoon, and Southern Illinois Healthcare. So these are our friends. We don't exactly know what's going to happen in healthcare just yet. The future may be a little bit uncertain, but we've picked the people we want to go forward with. And as you'll see, it was really important to us that all of these systems be strong financially. So I showed you their operating margins and a little bit about their balance sheets of days cash on hand and total debt to capitalization. We didn't want to be friends with people who just wanted us for our money. Okay? And we didn't want to have friends where we just wanted them for their money. Okay? We wanted relationships with people who had a commitment to academic medicine. Now you can imagine that the Washington University School of Medicine says, wait a minute, Steve, I thought you were us. And I said, I love you better than I love everybody else. But I don't think we can go this alone. And so the dean and I actually drove, and we met with the dean at the university, at the School of Medicine, University of Missouri, Kansas City, and we met with the dean at Southern Illinois University, and we found out that those medical schools were really very different than Washington University. Southern Illinois University actually trains primary care physicians. University of Missouri, Kansas City is a 6-year medical school, beginning in the first year of college. Very different than WashU. So these are actually complementary. So believe it or not, our medical schools and our nursing schools across the collaborative, they now have leadership roundtables. They can work on continuing medical education, they can work on clinical trials, they can work on anything they want to work on. But at least they're trying to figure out where they can make common cause, which is kind of unique among the nation's medical schools in terms of sharing services or sharing programs. But you can see for BJC, the collaborative essentially doubled our size. And so you might say, well, how does the collaborative fit into the BJC strategic plan? So I come up with a pretty generic strategic plan that I think applies to everybody, to every academic medical center I've ever visited. You want to do 4 things. You want to take exceptional care of people. You need to operate in a financially responsible way. You need to position your hospital, your medical school for long-term success. And you want to stay true to your social and your academic missions. And under each of those activities, we're all doing essentially the same thing. We all want to produce high reliability patient outcomes. I probably should put the word good in front of that. Good high reliability patient outcomes. We're all increasingly dependent upon clinical information management to do that. And we all are focusing on employee engagement as a vehicle by which to improve those outcomes. And you can see the ways we operate in a financially responsible way. And importantly, what I try and show you on this slide is all the places where the Bjc Collaborative fits in. We actually do clinical information management together. We lower our cost of operating together. We are building out a service delivery network together. and we are preparing for total cost of care accountability together. And the ways we do that, by the way, remember these are 8 independently owned and governed health systems. We buy supplies together. We save about $40 million a year as a group buying supplies together. We also buy capital equipment and instrumentation together by going to a bunch of 3-for-2 sales. So we have 20 vendors who give a catalog to the Bjc Collaborative, and they say, if you all buy together in this window of time, we'll give you 3-for-2 pricing. It's kind of like going to Joseph Banks. They have banks down here. You go to Joseph Banks, we all don't have to buy the same suit, but we have to buy suits in the same time frame during the sale, and from the same catalog or from the same store. This has been the big windfall for BJC. We have saved about $150 million on capital equipment and instrumentation since we started to go to 3-for-2 sales with 8 other systems. Are there any oncologists in the room? Okay, none. That's pretty remarkable. But the 8 cancer center leaders from these systems, and I chair their work group. So we have the 8 cancer center directors working together, and they're working on a playbook for prevention, detection, screening, and surveillance. They're working on a playbook for conferencing. We used to think that would be a shared tumor board, but it's really a complex case review via whiz-bang technology. They're working on continuing education programs, especially in palliative care and end-of-life care. And they're trying to figure out a way to do clinical trials, either non-therapeutic trials or trials that don't involve investigational drugs. So they're working on that together because, if you think about it, there are 18,000 new cancer cases every year across the collaborative. If we could figure out a way to take care of them in a real network, not just one that uses MD Anderson's brand or Mayo Clinic's brand, but a real cancer care network, it would be the largest care delivery network for cancer cases in the United States. We have a long way to go, but the collaborative helps us to make that possible. And then the last thing we've invested in, 5 of the health systems have a contract with Ibm Watson to basically share an investment in data analytics and care management models. We're learning together as we do that. It certainly hasn't been a panacea or a smooth road, but it certainly defrays the cost for all of us to share it, and we're learning together about how we're going to deliver care on a regional basis, not just within the BJC health system. So I'm going to leave you with these questions before you can ask me anything you want. As you leave here, think about whether or not you're an episodic care delivery system or a people-based system. Are the financing changes I kind of presented affecting you, and at what pace, and to what extent? And is it going to accelerate over the next several years or decelerate? Are you all ready and willing and able to change whatever needs to be changed to adapt to this kind of new model of care delivery? It does take money to do this, including segregating money for this kind of risk, which actually you have an advantage because you already have Viva Health as one of the tools in your toolbox. I learned a little bit more last night at dinner about the governance model for the University of Alabama, but there are academic medical centers among your colleagues who are still owned by their state universities. And state universities really don't have in their charter to be in the insurance risk business. And so how do they feel about taking that kind of accountability risk inside the university and onto the university's balance sheet? And this is probably the most important question. Who are your friends? Mainly in academic medicine, our friends are other academic medical centers. We're really good at staying within our universe of academic medicine, but when it comes to forging relationship with community hospitals, non-teaching hospitals, rural hospitals, who are our friends? How inclusive and diverse can we make our risk pool? And how do we begin to manage all of that stuff that may be out of our sphere of influence and control? Because we don't own any of the Bjc Collaborative members other than BJC Healthcare. And we all have to figure out a way to do this together because we're not big enough all by ourselves. Thank you all very much for your attention, and I'd be happy to answer any questions you have.
Steve, thank you. A really outstanding talk, and you've challenged our thought process. I think one of the things that's changed, as you've highlighted it, going through the change of healthcare, I think we see it here and we see it with you, the importance of a CEO in a health system has dramatically changed because of the complexity of delivering and actually managing healthcare in our current environment. So, thank you for an outstanding presentation, and questions that you have for Mr. Lipstein.
Sir?
Do you own all of the Bjc healthcare institutions?
We do.
Is there academic, is there training going on at those facilities, or are they strictly more of a community line?
No. So the question, just to repeat the question, does BJC own all of the 15 hospitals in the BJC healthcare system? The answer is fundamentally yes. We actually lease one hospital from a county in Columbia, and we have a joint operating agreement for our rehab hospital with HealthSouth. Everything else is an owned and operated asset. The medical school, the teaching hospitals, Barnes Jewish and St. Louis Children's Hospital are closed staff models. In order to be on the staff there, you have to have a faculty appointment at the Washington University School of Medicine. All of the other hospitals are open staff models. The faculty can practice at those other hospitals with voluntary privileges, and they do at some of them. They don't want to go to all of them. So the faculty, by and large, don't go to the rural hospitals. They tend, until recently, but for example, the cardiac surgery department does cardiac surgery at Christian Hospital up in North County. And the Siteman Cancer Center, which is a Washington University Barnes Jewish Hospital activity, is also going to go to Christian Hospital. In fact, the Siteman Cancer Center has satellites at Barnes Jewish St. Peter's, they have at Barnes Jewish West County, and on their outpatient South County campus. So the medical school clinical practice plan is not restricted just to the central campus. But they do have to work side by side with what they sometimes think of as competing physicians in all of our community hospitals. To your answer, are there students and residents at the community hospitals? I know that there are, okay, but it's pretty limited, and it's department specific. So maternal fetal medicine does some training at Missouri Baptist Medical Center, which is a BJC hospital. General surgery, I know, has residents and students at Barnes Jewish West County because they've been in the exam room when I've been the patient. But the 90% of our training activity probably still happens on the main campus. Sir?
How do you think the basic research enterprise can bring added value to this model?
So the question is, how does the basic research model bring value to this model? I shared with my colleagues at dinner last night a program that we just initiated called the BJC Investigator Program, which is a copy of the Howard Hughes Medical Institute program, where we invest, we're going to invest $100 million over 10 years in 10 scientists, $10 million per scientist, and they all have to be basic scientists. One of the things I learned when I served on the board of the Patient-Centered Outcomes Research Institute, and Francis Collins sat on that board, and Carolyn Clancy sat on that board, and I realized that basic sciences aren't getting, not only do basic sciences not get enough attention inside of our academic medical centers, but they also don't get enough attention in Washington, because Congress really wants science to convert to applications like that. And you know, basic science doesn't work that fast. But basic science has really given Washington University a lot of its reputation for excellence, for being at the vanguard of medicine. One of the things that we do inside of BJC is we don't adopt one brand. So Barnes Jewish Hospital is the Barnes Jewish brand, and it's affiliated with Washington University. Missouri Baptist Medical Center, which has its own brand, is separate and apart from academic medicine. Every one of our hospitals can be the best in the world at something, but it doesn't have to be the same thing. So if you go to one of our small rural hospitals and you realize that their hospital president can deliver a newspaper to every patient every day at 5 o'clock. It's a paper route of about 12 to 15. I promise you Will doesn't deliver a newspaper to every patient every day at 5 o'clock. But the basic science reputation of Washington University and our investment in basic science really gives us our leading edge opportunity. And so, but here's one of the things I learned about academic medicine over a long time, is not the best science in the University of Alabama, at the University of Alabama may not be happening in the departments that have the most money. So, and even within the clinical departments, I'm sitting in front of the chairman of the Department of Medicine, so I got to be careful here. But even in the clinical departments, some of the departments that are haves because of their professional fee earning capability or because of philanthropy or reserves still may not be doing the best science. And they don't typically give their money to other departments who are doing good science. So part of what we wanted to do at BJC was to be able to fund A scientists, A-level science work, the way Howard Hughes does, in departments that don't necessarily have access to a lot of clinical revenue. And Howard Hughes was a good model for that because they invest in people, not necessarily in program. And they don't make you write a grant every year. They're really, trying to find the people who they think are going to be asking the most important research questions that can change an entire field of inquiry. And so BJC wants to attach its name to that activity. And so, so we copied a lot of what they do, with their permission, by the way, with their permission. And you might say, okay, this guy's the hospital administrator, and he's making a $100 million investment in basic science. A, you only do that if you have enough money to do that. And B, it's a really good thing to do. It's really what we're all about. Now, it doesn't mean that I don't love the clinical sciences in terms of doing research, but they have access to revenue streams that the basic sciences do not. So this is our foray into trying to, and the other thing I will say about Washington University as a medical school is if you ask people who's doing the best science at Washington University, they can give you a list of names. And that list of names were all people that were there when I arrived 18 years ago. That was sobering for me. Because we have very good young investigators and very good senior investigators, but we seem to be lacking the middle layer. And it's hard to attract that layer from outside your institution, because you're trying to find people who are highly productive from a research perspective, who are happy where they are. And the more difficult part is they tend to be married to people who are happy where they are. So trying to recruit them to come to St. Louis, to the backwaters of the Mississippi River, and we tend to try and recruit them from the coasts, which is harder for us. It'll be easier after these hurricanes come through. But we really are trying to figure out a way to invest in the science base, because it really has been historically what has given academic medicine its sustainable advantage. Did I answer your question?
Yeah, comprehensive.
Question back up, there are two back there.
Just real quickly, what time frame did it take you to develop your collaborative? And as you did that, what was one of the greatest challenges you had, and how did you work through that?
So the question was, over what time frame did we establish the collaborative? We started calling people in 2011. So it's been up for we're in our 5th year, 12, 13, 14, 15. We're in our 5th year, so I'm off by one sequence. We're in our 5th year. The governing model of the collaborative is interesting. There are 12 people on the governing board, 2 members from each of the 4 big health systems that have academic affiliations, and 1 from the other participating health systems. And to be on the board, you either have to be the CEO of the health system or the chairman of the board of the health system. And we wanted the chairman of the boards to be there so that the collaborative wouldn't be dependent upon the personal relationships of the CEOs. And so I think one of our challenges is right now, part of what holds this thing together is that I have a very good relationship with Ed Curtis at Memorial, Mindy Estes at St. Luke's in Kansas City, Steve Edwards at Cox. And we need this to be an institutional relationship, not a personal relationship, even though people were the ones that built it. They decided, we were going to have rotating chair models, and then they decided that, BJC was really at the hub of this activity. We were the ones with the relationships on the eastern half moon in Illinois, which are different from the ones in Missouri and Springfield and Kansas City. So I'm now what they call the executive board chair, but it's really going to be important that whoever is the CEO of BJC after me feel that sense of leadership of the entire collaborative. That's number one. Number two is not all the collaborative members have to participate in every activity. So the IBM Watson contract I mentioned earlier, St. Luke's in Kansas City is not in that, Cox is not in that. And so I started calling St. Luke's and Cox the American League, and BJC and everybody in Illinois is the National League because of the Cardinals and the Royals. And the people in Kansas City didn't like that until they won the World Series. But that 4-hour distance between St. Luke's and BJC is probably a barrier. So for example, with Memorial in Springfield, Illinois, and BJC in St. Louis, we now have a single clinical engineering group. They manage all of our clinical assets, all of our clinical equipment and instrumentation together. It saved Memorial about $400,000 a year. So I go to orientation for shared services employees for BJC, and I actually meet employees who work at Memorial in Springfield, Illinois now. So what I'm learning is that there's a tighter circle network, and that 2-hour driving radius has kind of been key. And then the other challenge is really to make it institutional versus personal. Sir?
Yeah, so you mentioned Watson, that is going to influence medical care over the years. So go back to your risk model where you layered out different risks. What you didn't show us was the occupancy in that each risk category, because obviously that's a multiplying factor. So how much would you gain by improving basic health versus in making a more efficient delivery of health care? And so which one of those would be more beneficial?
It's a very good question. The question is, in the risk stratification, you've got a number of individuals in each group. How much could you lower cost by moving, say, the rising risk group back into the low risk group, or the high risk into a lower risk category by managing the overall risk factor versus just improving the efficiency of care within each risk group? It's really interesting. In the Iowa data, what it shows is that no matter how good they are at improving the quality of care, people progress into higher risk groups. And it's because of the biology of longevity. The longer you live, the higher is your risk of cancer, heart disease, dementia. And so part of what we haven't overcome yet is this idea that we can make everybody healthy again as they get older. Because, I've been to lectures on telomeres, and I know that my telomeres aren't getting any longer or any shorter.
So is health in the early phase of life the really important thing to do?
Absolutely.
In other words, before somebody becomes a teenager or as it becomes a teenager, is this where we're establishing our risk factors for disease? It's not based on genes, but it's based on how genes change in response to it.
So it's more fundamental than that. So early childhood development turns out to be key. We know that if you don't graduate from high school, you're going to live about a decade shorter than if you complete college. We also know that if you're not reading on grade level by 3rd grade, you tend to correlate with that segment of the population that drops out of high school. Okay? So education, so we have a program we've called St. Louis, and we've redefined a healthy delivery from one where we discharge a baby from the hospital at full birth weight with mom to a child who gets to 3rd grade fully immunized, complete eye and dental care, a body mass index appropriate to their age and height, and reading on grade level. Because we find out if we can get that 3rd grader there, they tend to be associated with a cohort that graduates high school and goes on to college. And if they do that, they're going to live a decade longer, no matter what we do in the American healthcare system. And so 80% of health status in America is correlated with income, education, poverty, lifestyle behavior, and genetics. Only about 20% is correlated with the care delivery model. And so if we're going to get into total cost of care and risk management, we're going to have to figure out a way for the healthcare establishment to be more involved in the socio-demographics of the population we take care of. Does that make sense?
So last question, and that was the last question. But I think you've highlighted that academic medical centers, if you are going to be in the total cost of care, you're going to actually have to be in the management of a lot of the socioeconomic challenges of the populations you manage. And that's an outstanding example, Steve, outstanding lecture. Obviously, it's not frequently that a healthcare administrator or CEO stimulates an audience of scientists and doctors as much as you did, but it was excellent, and we're glad that you're here.
Thank you so much.
This is a plaque recognizing your visit to UAB, and there'll be more discussions through the rest of the day.
Okay. Thank you all very, very much. Thank you for this. This is nice.